Hi, my name is Mazyar Shadman. I'm an assistant professor at the University of Washington and Fred Hutchinson Cancer Center in Seattle. At ASCO 2024, I presented data on behalf of my co-authors on a network meta-analysis comparing the efficacy of covalent BTK inhibitors for relapsed CLL. As we know, there are currently 3 approved covalent BTK inhibitors for treatment of relapsed refractory CLL: ibrutinib, the first-in-class BTK inhibitor, acalabrutinib, and zanubrutinib. While there are head-to-head trials comparing acala versus ibrutinib, the ELEVATE-RR trial, and also zanubrutinib versus ibrutinib, ALPINE trial, there is no head-to-head trial comparing zanubrutinib versus acalabrutinib. For that reason, recently we have seen a number of indirect comparisons. One example is MAYAC, or matching indirect adjusted comparison. And another methodology would be a network meta-analysis, which we used here. Basically, this is a methodology that uses more than 3 clinical trials and utilizes direct and indirect comparisons. After applying the initial criteria for selecting the clinical trials, we came up with 3 studies: ELEVATE-RR comparing acalabrutinib versus ibrutinib, ALPINE comparing zanubrutinib versus ibrutinib, and ASCEND, which compared acalabrutinib versus investigator choice of either bendamustine rituximab or idelalisib rituximab. As you see here, for example, for comparing zanubrutinib to chemoimmunotherapy or PI3 kinase inhibitor, we are doing an indirect comparison through the common comparator arm of ibrutinib in ALPINE, and also through ibrutinib versus acalabrutinib in ELEVATE-RR, and from there, acalabrutinib versus chemoimmunotherapy and idelalisib and rituximab. Briefly, the results indicate we looked at overall response, complete responses, and progression-free survival and overall survival. For overall response rate, we saw that zanubrutinib was superior to ibrutinib in terms of ORR, and this was statistically significant. There was also a trend in favor of zanubrutinib for CR versus ibrutinib, but this did not reach the statistical significance. Same for zanubrutinib versus acalabrutinib. Despite the numerical superiority of zanu versus acala, this was not statistically significant for overall response or for CR. For progression-free survival, we did the comparison after adjusting for COVID-19 related deaths. As we know, the ALPINE trial was almost entirely done during the pandemic, so we thought that adjusting for COVID-19 related deaths would be appropriate. We also looked at unadjusted comparison. So when we used the clinical trial definition for high-risk disease, zanubrutinib was found to be superior compared to ibrutinib, to acalabrutinib, and to chemotherapy / idelalisib rituximab, regardless of adjusting or not adjusting for COVID-19. When we only looked at del-17p, again, zanubrutinib was superior to ibrutinib and to chemoimmunotherapy and idelalisib rituximab, and it was also superior to zanubrutinib in the adjusted analysis, but not in the unadjusted analysis for COVID-19. In terms of overall survival, there was a trend in favor of zanubrutinib, but these did not reach the statistical significance. So in summary, we remind ourselves that the gold standard for comparing drugs in general, and especially in this setting, would be head-to-head trials. Many of us believe that the current head-to-head trials would give us enough information to discuss with patients and also have an academic discussion. But these indirect comparisons, including this network meta-analysis and also the MAYAC analysis, could help investigators, physicians, and maybe patients to have a good understanding of the relative efficacy of these drugs.